Thank you so much. I'm like a whole big emotional wreck. It's like listening to Dr. Joy speak and to hear what she said has set that tone for me already. It is really refreshing to hear that up front. I appreciate you all coming because you probably knew you were going to hear that and you're still here. So that means a lot too. And then lastly, I've never followed a JJ before, so it's 2 JJs for the JJ way. Turn my slide this way because I like to do it better on the computer. So I came in from Orlando, and I live in Orlando. I landed in Orlando in 1989, back in the day. I came to go to Disney. I had a 2-year-old in tow, and I was like, wow, America, you know. And I met the man of my dreams, and we married, and I came back the following year, and I've been here ever since. But I actually thought I was coming back to live the Disney lifestyle. Had no idea. So I'm somewhat still reeling, because it's not quite that, is it? So I've been around talking about what I do for a good while. I want to share some things today. Simply from that place of maybe these ideas might be useful, maybe you have similar ideas. I just want to say it's possible. I mean, it is amazing what's possible. And believe me, we've done this on a nickel and dime. We haven't got any money. So it happened organically, but it happened. So I hope it gives hope and courage, because you can get really overwhelmed with this stuff. You can almost just want to just run screaming. You know, many times I thought about just getting on a plane and going away. So the United States, I can say I was here since the late 90s, from 1989, but it was in 2010 that when those goals, before the 2010 goals came out, that I realized there's an actual plan. Didn't really know that before. So I was very intrigued by them. And when they mentioned the elimination of health disparities, I got really excited. I was like, okay, cool, now I get it. And then, of course, we currently have the 2020 goals, which are in place, and we're working hopefully very hard towards those. And they're quite lofty. They're even more, maybe, ambitious than the other ones. They say achieve health equity as well as eliminate disparities and improve health for all groups. So that's kind of something that has given me a sense of, okay, the data is really important. You know, you're in America, so behave yourself and do what you're supposed to do. So it's all about getting the data. And so I compared this slide. This is March of Dimes. It's an old slide from 2009, but it shows the Florida relationship to the 2010 objectives for the Healthy 20 people. Healthy 2010. And so look at this. We've got the adequate and adequate plus prenatal care. We've got preterm, low birth weight, and infant mortality. And Florida, you know, wasn't doing quite so well, but at least we could compare them side to side. These are the 2020. And what I noticed when I looked at this slide, this is also from March of Dimes, I was like a little bit concerned because I noticed something. So I'm going to flip back a second. So let's just take adequate prenatal care. That's a measure of how many visits a woman is having in her pregnancy. And if you notice that the blue bar, which is the US 2010 objective, is 90 there. But for 2020 objective, it's 77.6. And I'm not a statistician. I don't know stuff about this. I'm not an academician. I'm a midwife. I'm a direct entry midwife at that. I'm not even a registered nurse. So I'm just telling you out loud. So when I saw that it had changed in terms of that objective, I was like, is that because then maybe we're going to be closer to it? Because Florida was about the same for both decades. The other thing then is, of course, if you look at preterm, and this is my biggest concern, preterm birth is really important. And I looked at that, 13.8, and then 7.6 was the goal in 10, but it's 11.4 in 20. So hopefully during the course of the day, someone who's much more learned than I can help me understand how did that change and why. There's probably a very good reason, but I'd like to know more. The one thing I know though is this: every other graph that I've seen that shows racial groups in comparison with whichever health ill is discussing at the time, without reading on the side or the legend, you can tell the purple line is going to be African American. I learned that within a couple of years of getting here. Didn't matter, it could be diabetes, it could be heart disease, it could be anything, it doesn't matter, right? Like, you don't have to struggle to wonder, which race is that at the top there? Which race is that is quite markedly different to the others? So, this is preterm births. I'm in Orange County, which is where I live, and this is an old graph, but I want to show you that because later on I'm going to make a comparison. So, I like to just get to the bottom line. Our babies are dying. the name of our conference today, Can I Live? It's clear, this is what's wrong. The babies are being born too soon, premature. They're being born too sick. They're not strong. They're not making it. They're not surviving that first year. The infant mortality represents babies who didn't make it to the first birthday. And for the longest, I worked on the infant side of things. I was very focused on the infant mortality until it hit me. Oh, hang on, the mothers are in jeopardy. Completely disconnected. I'm a midwife, I'm poking bellies all day. Worried sick about the babies. The mothers are in jeopardy too. 3 to 4 times as many African American women are dying as white, but 2 to 3 women die every day in the States. Which, if you compare that to developing nations, is not that horrible, but on the other hand, dying in a developed country due to childbearing issues. This is a picture of me at the Capitol with Amnesty International. I did some work there when we were looking at maternal death. Anybody's familiar with the report that came out, Deadly Delivery? It's a very important report, and it outlines the impact of maternal morbidity and mortality in the States. So we know about the causes. I'm not going to belabor these. Obviously, premature low birth weight babies aren't going to make it or don't do well. Mothers not being well before pregnancy impacts their ill health during pregnancy. Stress, depression, racism, the social determinants of health. But I also feel like we have to talk about access. Because we know that they're not getting into care, but it's also the type of care, the quality of care. So having access to quality is key. And then the systems, as Dr. Joyce pointed out. So where are we going wrong then? I think the system's broken. I think this is the problem. You know, it's not just whether you're uninsured or underinsured. Many of you have insurance, right? Anybody getting along well with their insurance company? I've got a $3,000 deductible. I'm sorry, it's not doing me a whole lot of good. You know, I mean, then all the calling and the hook, and which 800 number and hold the line for 45 minutes and, You just want some health care. So it's not that, it's just the insurance issue, but it is a big piece. Being indigent, being disenfranchised, all of this has an impact. And women are falling through the cracks. I think the most confused amongst us are the actual providers, the agencies. We're not talking to each other. We don't understand each other's systems. We can't get in. I have to keep my bag lines, my cell phones handy. No point calling the front desk. It's much easier for me to call my buddy at such and so agency and say, look, girl, can you help me out? That's not a system, right? That doesn't make sense to me. The gaps are worse for the mothers because they keep falling through them and they're left there hanging, left overwhelmed. And of course, like we've already heard, the institutionalization of the systems are at fault. This isn't about personally mitigated racism. This is about a system or systems that hurt. So one day I was thinking about, I better name this thing that I'm doing, and I didn't have any real brilliance, so I came up with the JJ way because I was kind of lame and I was like, that will have to do. So I'm Jenny Joseph and it's called the JJ way, so there we are. But it was based on this fundamental premise, simply this. Every woman wants a healthy baby. That's it. Like every woman, every one of you that's a parent in this room knows what I'm talking about. You dip that urine, you see 2 lines on the stick, your knees go to jello, your heart starts, right? Because you want a healthy baby. Because you're scared about, will it be okay? Will I be okay? Every single one of us, and everyone deserves a healthy baby, a better outcome. I used some pictures in the slideshow from a book that I published a few years ago. These were pictures we took of women from the practice. This is one of them. These are everyday women from around the way. And what was interesting about the day we took the pictures was we weren't really trying to take pictures, we were just kind of goofing off with the digital camera. And we had some fabric, and we said, let's drape women and let's mess around. But what came out was a really amazing set of pictures, really authentic, we're just having fun. But what I really noticed too about them was how they've spoken to the women and the families that come through our practice. The mission of the JJ Way is simply this: let's inspire some change in maternal child health systems. Let's re-empower the birthing mother, the family, the community. Let's support the providers and the practitioners and the agencies. Because we can change things for the better if we support women from that place. If we can provide the optimal setting, culture, and environment for her, she's going to get her best outcome. And I'm here to say that that works, because that's what we've been doing. So this is the vision of the JJ Way. Every woman has access is the number one tenet of all of the 4 tenets that we have: access. Access, access, access. Connections, knowledge, and empowerment. The empowerment being the end result. That helps every woman get her healthiest possible pregnancy, birth, and parenting experience. So for me, it's all about the big belly. These, again, are these pictures that I was talking about just now. There's not many opportunities to see pictures of positive images of black women, especially pregnant or parenting black women. I haven't seen another book since I made my book. This was published in 2008. I don't think anything's coming, could be wrong. But it's really important to reflect women to themselves. This is for the skinny women, right? Those that shouldn't be able to carry their babies to term, high risk for this, high risk for that, no boobs, so they can't breastfeed. Those ones. This little one here, she spits out 8-pounders. She's done it 3 times. No drama. And the big girls. Nothing wrong with being big if you're healthy. And this was one of my very nervous first-time moms, scared out of her wits. All day long, every 5 minutes on the phone, panic-stricken and went to term. So we do this work by increasing access for the mothers to our team. They can get in the door, they're going to get care. Once they get care, they start to trust. Once they start to trust, they start to disclose. Once they disclose, we can find where's the gap. It's that simple. We create connections. The first connection is let's get this mother bonded to her child. How many of you can relate to being scared to connect to your baby? For fear. Is this one going to make it? Am I going to miscarry? Am I going to go all the way? I can't afford it. I can't manage. I can't. The fear, the complete drama that just envelops a pregnant woman who is not secure in that knowledge. Every woman is going through that. So we want to reassure and encourage women quickly. It's okay, bond. Go ahead. This little one, you're going to be fine. Amazing the difference that makes the minute she switches her mindset. Now she's interested. Okay, well, what do I have to do? Oh, there's your education. Not shoving it down anybody's throats, not beating them over the head, not judging, not blaming, not, oh my gosh, girl, none of that. Because at the end of the day, this woman is empowered. She's asking how can she get a full-term baby. So we want the father involved, we want the family, everybody connecting to the team. But then we also want our team connected to the resources, because we have to stand in the gap for those resources until the women can do it on their own. You know how it is. You can't get through to the Medicaid office. Tell the truth. You can't. And you get on the computer and you're supposed to figure out how to apply with all of these convoluted and bureaucratic hurdles to get Medicaid or to get services. You know we can't just put that on mothers. So once we've inspired that knowledge, we want to encourage the empowerment, like you say. So access again to the system is the key. Creating a maternity medical home. And how we did it was simply say to anybody who presented, if you're pregnant and you want care, you're in. Like that was it. The front desk barrier was removed instantly because that's where it all stops. America breaks down at the front desk. And I'm not here to malign front desk people. You guys are great, you're doing your job, you're doing what you've been told, you're trying to hold the job down, you've got stuff to deal with yourselves. Front desk works, right? But front desk doesn't work. Front desk is killing our babies. Because if she gets turned away, she's not coming back. Why would she? So the access was the key. Support of the team is the key. Access to an environment, and I'll talk more about that. And then quickly being able to find her gaps and help her fill them. This is the team that I work with. We're a little skeleton crew here, hanging in. I have 2 licensed midwives, CPMs, certified professional midwives, 1 nurse midwife, and myself. And then I have an assistant director and 2 medical assistants, and that's all we can afford. But we see about 600-700 women a year through our clinic, and we're doing that, doing midwifery care. So I'm not saying everybody should do midwifery care. I'm saying everybody could consider doing midwifery model care. Difference, right? Okay, so the easy access clinics are just that. Easy access clinics mean there is no barrier, there's nothing. No one can turn you away for no reason. Like, you can't come up with a reason. You could have the head crowning. You're not too late. We'll take you, come on. Right? Like, what would we do different? Like, if there's another something on the other side, that's fine. But there's nothing on the other side of, no, we can't help you. What are we doing? What are we standing for? So this was the open house for the new site. I just opened it a couple weeks ago. That is indeed Daniel Webster, Congressman, standing, cutting a ribbon with me. Yes. I'm very proud of that. I was surprised that he came, but he did, and he was very supportive of our work. He's our local congressman, but he was almost the Speaker of the House. I don't know if anybody knows him, but anyway, this is our building, and you would look at that and think, oh, well, that's very commercial. Yeah, we have got the attorneys down the hall, and we've got the accountants underneath, and when we are delivering, they can tell. But we go on, right? So the birth center has birthing rooms on site, but we also now have a freestanding clinic, which is purely for women's health and pregnancy, no birthing. And I differentiated that on purpose. So we provide an environment that speaks to what we're looking for. We have one goal with our program. You're going to get to term. So if anyone speaks to me and they say, well, Jenny, what kind of cultures do you have at the birth center? What is your group, or what is your most, the biggest number of race, or which race? I can tell them really quickly, well, we just have a culture that you're going to have a full-term baby. And if you hold that, it happens. All of the staff work from that way. We make sure that the families that come through understand that. Even the little kids get to understand that. Children are measuring their mother's belly, they're listening with the Doppler. We turn the Dopplers up loud. We make sure everybody hears the robust beat of the heart down the hall. It's about creating an environment that says you're safe, that you're welcome, that you're okay. So this gives you a little sense of how it looks. We've got pictures on the wall. These are some of the other pictures. I did those in color, and the ones in the book are in black and white. But again, these are local women whose pictures are on the wall. I'm all about the couch and the soft furnishings. We don't have any metal stools to scare men and have them be frustrated that they have to sit for an hour on a metal stool while they wait. We've got couches in every exam room. And oftentimes you'll go to an exam room and the dad is sprawled out on the couch with legs up on the side and the kids are climbing. But they're comfortable, they're ready, they want to hear, they're learning, and they're participating. And then we have the delivery rooms, which is not what this is about. I'm not trying to convince you guys that midwifery or natural birth or water birth is the thing. I'm just saying that women like options. They like to have choice, and they like to know that it's available to them. So we do take Medicaid for our birth center births, but we're not looking to encourage people to do the birth center births. But interestingly enough, women from Easy Access Clinic keep choosing birth center births. Majority of them go to the hospital, and we encourage that, and they deliver at the hospital with the residents, and they get their epidural, and they're happy. And we're not trying to change their mind. We want them to have their birth. But we do have birthing pools in every room. So again, I mentioned the connections. I mentioned the fact that we also want to connect the staff to the mother, to the father, to the family, to the neighbor. We want to connect the staff to each other. We want to connect the agency to the agencies. We want to connect. Right? We're bringing it in. Who's in the center? The mother baby. Everybody else is peripheral to her and managing to support her, and the team is all part of that. And she and her husband, partner, whomever gets to join the team. Our community then is who's out there doing work, trying to get this done as well. Our best supporter currently is the Pregnancy Crisis Center. Before we joined hands with them, which we didn't think that was a match, and it is. Why? Because they have pregnant women. That's it. And pregnant women go there in crisis. And whatever information they share with them, they also are willing now to share with them. And you can go down the road here and have this care if you are going forward with this pregnancy. So we say, yes, please, we'll partner. We'll partner with anybody who's working with pregnant women. So the other tenet, the third one, is expecting a full-term healthy baby. That is the knowledge. That's the childbirth class in one. That's it. Because immediately the question follows right behind, well, how do I do it? And you fill in the blanks. We individualize that education. We do baby showers, we play games. We have clinic waiting in a circle. They don't know it. We call it the classroom behind the scenes, but it looks like a waiting room. And everyone's in the circle because they're talking to each other. The educators are amongst them in the circle. The doulas are sitting with them. The childbirth educators are sitting with them. And nobody really knows they're getting class, but we are steady marking down what we've covered, how far they've come, what do they need. Before they get to 36 weeks, they've got a birth plan in their hand, wherever they're delivering. No one ever had to show up on Wednesday afternoon with 2 pillows and a husband, right? These are barriers. People can't always accommodate that. So we also educate and train paraprofessionals and professionals. We do midwifery training on site. But more importantly, we do community-based training for doulas, childbirth educators, and lactation educators on site. They intern at our practices. We look to bring the community to us to say, how can we support you and your agency's needs? So we've managed to train 60 plus perinatal educators for our local Healthy Start. And in Florida, the state Healthy Start pays for those women to do home visits. So now they're doing outreach, they're on the ground, they're certified in these disciplines, and the state reimburses the Healthy Start agency. Everybody wins. Everybody wins. Because all of a sudden, you've got women and men who are trained and able to deliver education, who can identify problems, who can navigate systems, who can help support. They extend the practitioner into the community. They're deployed into the community. And best of all, they look and are congruent with the community. The value of that, I can't even speak to. I mean, it's just, the ripple effect is amazing. And then, of course, we know that agencies want to know more about perinatal health and the impact of perinatal work. So this is a graph just showing you very quickly. This is Volusia County Healthy Start. And along the bottom line, you'll see on the zeros, is the childbirth education and the breastfeeding education units that were delivered through the years from 06 up until 10 when we did our first training. The first batch that we trained, there were 30 women trained. And you see the exponential rise in childbirth education and breastfeeding education delivered in that same county with that same team. And other than the cost of the training, nobody spent any money. They just started making money. Because guess what, when they were running those classes, do you think anybody came? There they were at the community center every Wednesday waiting on people, and oh, they're not coming, right? When you deliver the education one-on-one and face-to-face on the couch, at the community center, at the store, wherever you find a person, you're delivering the education, she's getting the education, and look at the data. And of course we have to start recruiting early, because we don't have enough people. So, the empowerment is obvious, I'm not even going to break that down. But it's not just empowering the mother and the father, it's empowering everybody. All of us need to be empowered in this work. This woman in this picture, I always tell her story because she was using crack when she started with us. So she should have been totally out the door immediately. But because we have the no one turned away policy, we bring them in and triage the patients before we figure out where they need to go next, and then we also expedite them getting there. I don't know if you have the same issue in Texas, but getting into high-risk OB, perinatology, is like impossible. If you don't navigate that for her, she's not getting in. You can't just say, well, there's the appointment, or here's the phone number, or see you later, come back when you've been sick. Doesn't work like that. When we acknowledge that we have these gaps and are prepared to step into them, we mitigate the resulting outcomes. This girl was crack addicted, strung out, 16 weeks. She presents at the birthplace because she knows she's going to get seen. We have to turn her around and send her right to the high-risk OB. She got into rehab, she got into a residential, she got clean in the pregnancy. She was supposed to stay with high-risk clinic, and she aggravated them so much, they sent her back. Like, go back to the midwives, we can't cope. And we took her back, we were happy to have her because we were able to collaborate. But this is her at 36 weeks. Look at that picture. 36 weeks pregnant, she went to term, she delivered full term, she breastfed for a while. Now she's back out on the street. She relapsed right away. Baby's with the grandma. But during the pregnancy, look what happened. So, the key is that we all have a role to play. We do this in our own little world, in a microcosm, but we've seen it work over and over. As long as we know that we can care about the patient, we recognize the patient, we call her by her name, we relate to her, or she relates to whoever she feels most comfortable with. That's not a big deal in our office. Many of the women are much more happy with the medical assistants than they are with the midwives. Fine with me. It's not about who's in charge and who's got more credentials. It's about how can we get this woman what she needs. We also want to make sure, again, that we're engaging the families outside in the communities, the practitioners. So my suggestion is that if we can apply all of the principles of the JJ Way to all of these areas, we're okay. We give access to each other as practitioners, as providers, as agencies, as policymakers. There's all of these different disciplines. If we give each other access to each other and our knowledge and share our knowledge and our work, we stay connected, we learn, we will be empowered too. I want to tell you about Shannon because her story illustrates just that. Shannon was 17, she dropped out of high school, she had a lot of preterm labor, it was her first baby. So she'd even been admitted one time for the preterm labor. They managed to stop the labor, they were able to get steroids into her. She was primed and ready, but she made it. This was about 30 weeks when she had this happen. But we couldn't figure out why she was having such a hard time. It came down to she wasn't gaining weight, her diet was really poor. And so we figured this out. We put her grandma and her boyfriend on the food team and started having her go to her boyfriend's house to eat, because it turned out she was living in a hotel room with the mother, her mother, who had a 2-year-old, and the mother had had her 2-year-old through our service as well. Her mother had one of those oopsie, you know, those pregnancies that happen 30, 38, 39 years old, be careful. Anyway, the mother was in this hotel room with her boyfriend, the mother's boyfriend, the 2-year-old sibling of Shannon, pregnant Shannon. Is there any surprise that she was losing weight, having preterm labor, and not eating? But what was interesting about Shannon was that she bonded to Katrina, my medical assistant. She was very close to Katrina. And so we kept her with Katrina through the pregnancy, and of course we were expecting her to deliver in the hospital. She did duly go to term. Her mother, the grandma, was clear she was having a hospital birth, until one night I get a phone call from Shannon in labor. "I'm coming to the birth center, Miss Jenny." And I'm like, huh? I had no idea. So we admitted her to the birth center. So you can see Shannon here. I put her in the water birth pool. That's the plastic wrapping over the tub. And here's Grandma, who looks like she got over that, right? She was okay with, oh, look, Shannon's in labor, so Grandma became doula. And look at Shannon's face. She was really lost in that labor world that people go to, right? The thing here is that, and this happens a lot, Shannon had no clue. She hadn't done anything because we were expecting a hospital birth. She hadn't done Lamar's class, right? 4 hours later, boom, there's the baby. Literally, we put her in the water and we left her alone. And you can tell by Shannon's face that she wasn't present, right? There's a baby on her belly and she's like, what? But that's how it works. Because if you leave it well enough alone, it works, right? So the fact that this girl almost had this child at 30 weeks, but instead went all the way to term, the fact that she had an option, which wasn't even in my radar, and I was the midwife. I was expecting her to go to the hospital like everybody else who goes to the hospital with their first baby and has all the trappings of being in the hospital. Her mother had just been through that whole process 2 years earlier. Shannon sat in the tub and went, and here she's it, here's the baby. So she had a natural birth, 7'5", 39 weeks, and it was her choice. But look, more importantly, the baby's dad was the first to hold the baby. The significance of that cannot be overstated. The baby's dad was the first to hold the baby. Not the nurses, not the pediatrician, nobody running up down the hallway with the child. The mother had the baby skin to skin. The father had the baby in his arms. Yes, he looks like a deer in the headlight. Blindsided. But do you think that moment may help him to readjust and figure out what's next? What's coming for him and his family? And Shannon sent me this picture later. This is her baby. She nursed her for 9 months and she was sort of nursing and back to school. But Shannon's baby, toddler, was feeding her own baby doll. Little white baby doll. I just thought it was the cutest thing. And it just shows you know, I mean, this is what's possible. So anyway, we were clear that we were onto something with this work, and we saw an increase in the birth weight, the gestation, the breastfeeding starts, regardless of whether they were in hospital or the birth center, didn't make a difference. Everybody was thriving. We got some funds to do a study back in 2006, 2007, and the outcomes blew us all away. We enrolled everybody prospectively. It was not a let's pick this group or that group. The only criteria was that you had to be in the easy access clinic, not the birth center cohort. Birth center women are healthy, there's nothing wrong with them. These were the women that were at risk. Of the 100 women we enrolled, 95% of the babies weighed 7.5, 95% of the women went to 39 weeks. No low birth weight babies for Black or Hispanic in the entire group, not one. Thank you. I put it in the bar graph just to kind of do the comparison. I compared to Orange County, my county. I compared to Florida. So that's the blue and the purple. And the yellow is our numbers for our overall population, and you can see the zeros for the Black and Hispanic. So we didn't drop it a couple points. That's what I really want to point out. If you look at the Black race for Florida and Orange County, 20%. How is that possible that you can carry a 20% prematurity rate and that be okay? The only way it's possible is because we accept the system. Yes? We know it's wrong. We know it's not something that we want to see, but it's continual. Been here 26 years. 26 years. So that graph I showed you earlier, you can see from here, if we had plotted our numbers, the bottom line would have been a 0. We would have been able to put where that purple heart is. I've never seen a graph like that. Never. I'd be happy though if they just dropped down into the bunch of everybody else. And just so you know, I don't think that's acceptable either. 15% prematurity is an average? What? No. We also found our C-section rates just automatically dropped. They run around 25%, and these are women who go into a hospital without a midwife or a doula following them necessarily, and thriving on their own because they're empowered enough to say, no, step back, put that down, I'm not having that. Give me a minute, let me push. If that's enough to make the difference between a scar on your belly and the morbidity, the ill health, the longevity, the postpartum depression, all of that, the difference between saying, no, I'm okay, give me a minute, and going down that road of being a statistic, then that could be a start. It could be a starting place. So that doesn't cost any money. The other thing is, of course, we saved a lot of money. Automatically, we saved a lot of money. March of Dimes says 50,000 or so is the cost of a premature baby. So doing little math, and I try hard to do math and I don't do very well, but of the 280 women that we counted in 2011, for example, 39 of them should have had a preterm baby if we use the Orange County rate. But there were only 5. So 34 babies stayed in the belly. And that came up at 1,700,000, just those 34. So this is small numbers, right? This is little teeny tiny practice in this big old state where we're spending a fortune. So I really feel compelled to say that JJ Way saves lives, because I think it does. And I think it's important too that we let the community be aware. This is our Florida statistic. It was for 2008, 1,600 babies are dead before their first birthday. We went to the city hall, we talked to the mayor, we had a proclamation made, because we think the next step is to get the awareness out there and to keep talking to communities. The Perinatal Task Force was developed then for that reason. It's a national organization. We're looking to transform these outcomes, not just have a dent. Transform, eliminate, eradicate. We have a support network that's national. We provide a toolkit. We're building this organization to grow safe spots. I call them perinatal safe spots. And in every maternal toxic area, which is every area in this country that looks like how it looks, that you know which area I'm talking about, which zip code, that there should be a safe spot in every one of those. I've got in your package just a little handout about what that is. But the National Perinatal Task Force Toolkit is looking at 3 ways of doing this work. Using the JJ Way model for clinical practices, using the perinatal community health worker model, and using the maternal justice model. Those 3 pieces together can transform care. I'm going to give a shout out to the Austin Perinatal Safe Spot. I'm so proud and I'm so grateful to be here, thankful for you women and men on the ground who've done this work, who are leading the way. Thank you, IUPRA, for doing what you're doing, because this is so encouraging. There's a work called Listening to Mothers. It's through Childbirth Connection. I encourage you to look into that. Lots of data about what the mothers have to say. It's important that we listen to the women because they're the ones. They know. They even know the solutions if we just listen. I want to play a 2-minute clip. Have I got 2 minutes? I'm going to play, or Leona's going to play. Who's going to play? I'm going to play. I'm going to play. Am I? I am. Yes, I'm going to do it. Okay, hold on for me, sorry. It seems like I can't see my arrow. It's going to have to come up. Okay. There it is. How do I get to make a big screen? Here we go. Okay.
Well, I think, at this point, the American
if you can make it loud. You can help me make a big screen as well. Sorry. Maybe we can put the mic to okay. Is there volume maybe? I met an Italian filmmaker who came to Orlando to make this documentary, and it's really powerful.
Be right at you quick.
Well, you can play the that size, but the question is the volume. Okay.
I have a dream.
Thank you.
My 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character. I have a dream today.
Black women in America have very little opportunity to speak and be heard. If you are African American, you are likely to have a higher percentage of any ill.
I feel like different races have different options. If you ask a doctor, is it safe to go to midwife? Their answer will always be no. They're using the scare factor just to make sure, at the end of the day, it's all about money.
African American women get treated different, totally different. When they go into these doctor's offices, when they go into the hospital, due to they may go in with the hair flying, even that the hair is not all there together, and because of that, these nurses judge them. My American dream is that we all be treated the same. We all be equal, no matter about the skin or the color. It shouldn't matter what type of insurance you have. Everyone should be treated the same way with the same care.
I feel easier for our women of color to, I just want to let the word give up. It's something that's instilled in us, or instilled in like the, people of color, that this is what we have, this is what we're gonna get. Instead of reaching for the stars, this is what this is all we got. This is the United States.